I would like to introduce Mr. Hassan Malik, who is a surgeon at the Liverpool University Hospitals, to give us a presentation on the surgery for cholangiocarcinoma, when it is possible and what is not. Thank you so much.
Right, well, thank you again, and thanks, Helen. Been doing this for about 10 years, talking in this meeting, and it's the first time you kind of held my feet to the fire and said, "What is operable? Tell me now," because I guess that's what you want to know. The problem with that is that surgery is still an art form, you know, and there's a number of surgeons in the room. They'll all have different opinions. This is my own personal views, my own personal journey, and please follow me. Let's see where it goes. Yeah. As a surgeon, I have no conflicts of interest. I'm not supported by any drug companies, whatever. But there are some pictures in here of operations, so if you find that unsettling, please just be aware of that. Cholangiocarcinoma, as we've heard already, it's a kind of disease which involves several anatomical parts. The bit I'm going to focus on is the perihilar intrahepatic bits. I'm not a pancreas surgeon. I don't really deal with the pancreatic distal tumours there. We do know that the incidence of cholangiocarcinoma is increasing, and the NHS England Get Data Out project did show that biliary tract cancer in its entirety, it probably has overtaken HCC, certainly in England in 2020. So coming back to the BSG guidelines, a lot of us were involved in this, including Helen and the team from MMF, but also Cholangiocarcinoma UK. And what does it say about surgery? Well, it should be undertaken at centres which have a high volume with expertise in surgery, but all the other specialties that you need to do this operation. Well, when you look at the data that, again, has been funded by AMMF, this has shown this kind of variation here. This is Liverpool up at the top, so we're doing the kind of highest rate of resections in the country, but there is this kind of group of missing patients, and the assumption that the incidence of this disease is roughly the same around the country. Obviously, different tumour boards, different MDTs are making different decisions as to what is operable or not. So that's one thing to just think about. And this really talks about this idea of variation in healthcare. And the key thing is to reduce the bad type of variation, which is our own personal inability as doctors to kind of use expertise and manage patients, but improving the good variation that makes care personalized, as we've heard with the kind of genomic testing, etc. So the other data that you probably haven't seen is this, which is more interesting. This is from NHS. This is his hospital episode statistics data. This is contemporaneous, so this is up to towards the end of last year. So this is all centres across England. There's about 2,500 liver resections happening annually across the 20-odd centres. The average number of resections for liver is about 125. So we were able to pull out the diagnostic code for cholangiocarcinoma. Just to also make it clear, there's probably about 4 to 5 liver surgeons per centre, so each surgeon's probably doing about 30 liver resections on average. Obviously, we have people doing more and people doing less than that. So when you look at cholangiocarcinoma, this is the what you see in terms of the data. Just got to go there. Right, so you got this kind of range here in terms of primary cholangiocarcinomas having a liver resection. It ranges from 0, which is slightly surprising, to just over 10% in Liverpool, and the average is just over 6%. In Liverpool, we're probably doing twice the number of resections, liver resections for cholangiocarcinoma as a diagnosis. The other thing you can pull out, and this was the challenge with the older data, is how do you pull out the perihilar cholangiocarcinoma cohort, because this is the kind of most extreme end of liver surgery, and it's the most challenging operation. But going back to this newer data, you can pull out hepatogeginostomy, which is a biliary reconstruction with liver resection. So an assumption that this happened for cholangiocarcinoma rather than someone going under a bus or something like that, then you can identify patients with hilar cholangiocarcinoma. So there's about 217 resections for hilar cholangiocarcinoma in England over that 3 years. So again, when you look at this, the rate of resection for hilar cholangiocarcinoma as your liver resection is just under 3% across the country. In Liverpool, it's probably 3 times that much. To put that in context, if an average surgeon is doing 30 liver resections a year, they're probably doing 1 hilar cholangiocarcinoma resection per year annually, on average. There will be people doing more and less, obviously. So there is this older guidance from OGIS, and this suggests that highly complex operations like this should be done by a kind of core team of 1 or 2 surgeons. And certainly in Liverpool, we've adhered to that. So it's myself and my colleague, Mr. Fennick, who do pretty much all of these cases. Now, I have to say, you know, I've had the honour of kind of looking after over 1,000 patients who've had liver surgery under my care. And if you look at me, even though I'm doing less liver operations now, as I come towards the latter part of my career, about 1/5 of the operations I do in the liver are for hilar cholangiocarcinoma. So how do you decide on which patient is operable? So what are the factors that I use in the tumour board? Obviously, it's the technical aspect of resectability, and you'll have 10 surgeons, you'll have 12 different answers for that. Then there's the oncological factors in terms of, is it sensible to do this operation in terms of the biology of the cancer? But also crucially, it's about the patient comorbidity and the outcomes of this type of operation in your hands and your centre. And using that, you can risk stratify. And certainly for cholangiocarcinoma, it's always going to be up there, the kind of highest risk type of operation. And the challenges as surgeons we face, the complexity of the anatomy, the anatomical variations, the assessment of the tumour extent, the physiology of the patient is jaundice. We had a talk earlier on about management of jaundice, the technical demands of the operations, the underlying liver disease, the vascular resections, neoadjuvant therapies. I know John Primmer is going to talk about that tomorrow, I think. And I think we are quite nihilistic in the West in terms of how we manage this disease, certainly compared to our colleagues in the Far East. The absolute contraindication in our tumour board would be metastatic disease. There's no point putting someone through a complex high-risk operation if it's ultimately not going to help them. And obviously the patient has to be fit enough for that operation. So that's the answer. Okay. Now in terms of perihilar cholangiocarcinoma, the things that make surgery more successful are being more radical to try and get a negative margin. That may require vascular resections and also taking lymph glands away. So in terms of the radicality, as the tumour grows from the left liver down to the right, you'd start with left epitectomy or a left lateral, or left epitectomy, extended left, etc. And similarly, as it grows from the right to the left. So as the tumour grows and the extent grows, you can take more and more liver away. You've heard, or you may have heard of the bismuth classification. This is something that has been used for a long time, but this talks only about what's in the bile duct. It doesn't tell you anything about the vessels and what's happening around it. And one of my previous research fellows, about 6 years ago, published this, which suggested that combining bismuth classification with an assessment of the vascular involvement increases your success rate at identifying patients who are operable on your imaging, etc. And then there's this paper from Bill Jarnigan and the guys in Sloan Kettering and the AMC clinic in Amsterdam. And this defines that a bit more as a local T stage. And tumours that are locally advanced, they're less likely to be resectable. And a T3 tumour would have, say, an atrophied right liver with a encasement of the vessels to the left liver, for example. So in terms of vascular resections, well, this is an example of a T3 tumour who had a right epitectomy with portal vein resection reconstruction, and about 1/3 of our hilar cholangiocarcinomas have that done. And we know from this meta-analysis that if you do this vascular resection, patients will do slightly worse than if they did not require a vascular resection. That's just common sense. The tumour's more advanced. But it's still worthwhile doing this type of operation because you can offer patients long-term survival. When you look at arterial resections, certainly all the data seems to suggest that even though it may be technically possible, the outcomes aren't that great. So certainly in our hands, if the future remnant liver artery is involved, we probably would not be looking to offer an operation, but that's where I think giving chemotherapy before the surgery may be beneficial. In terms of lymphadenectomy, this is the type of nodes you take around the hilum of the liver, and that allows you to stage the patient. So if you look at the schematic, essentially bismuth 4, which is there, yes, you can still resect those patients. You can do an extended hepatectomy there. So the only perihilar tumours which are technically inoperable are really when there's vascular invasion involvement that cannot be reconstructed. Obviously, in that situation, we may have a discussion about liver transplantation, but we're not really going to cover that today. So when you look at the outcomes from surgery, and this is part of the International Perihilar Cholangiocarcinoma Collaborative, over 2,000 patients, the results from resection are actually quite good, especially for the smaller end of the spectrum in terms of tumours. And this is the Liverpool data in terms of hilar resections. In terms of intrahepatic cholangiocarcinoma, I'm just going to focus on the special circumstances, and this is really the cases that need some form of complex liver surgery rather than a standard hepatectomy. So this is an example of a patient with a left-sided tumour encasing the blood supply and the bile duct to the right, in which we performed a resection of about 2/3 of the liver and reconstructed the bile duct. The things that worry us as surgeons are vascular resections around the vena cava. Often this is high risk of bleeding and dying, but you can operate and do these operations. And we've done quite a few of these cases in Liverpool where either we've done a primary resection of the vena cava and just stitched the hole, or alternatively in a tumour like this. And there's another intrahepatic cholangiocarcinoma which is encased in the vena cava, and we put a patch of a bovine pericardium, which is a bit of tissue from a cow, and did that reconstruction as this is showing. Or occasionally you'll have massive tumours like this where you have to reconstruct the whole vena cava with a graft there. So in terms of you've done the operation, what's the prognosis? Well, actually, with surgery, the outcomes can be quite good, and this is an older paper for us from Liverpool in terms of all cholangiocarcinomas and survival. But we also know that some patients will not benefit from surgery, so decision-making is the issue, and about 16% of patients, surgery is futile. They'll have complications, they'll recur, they'll die, and so really what we need to try and do as surgeons is trying to reduce that number of cases and try and give everyone who's having an operation the morbidity of surgery a long-term chance of cure. How do we do that? Well, it's the MDT. I mean, that's the message. So this is an example of a patient who's jaundiced with a cholangiocarcinoma. This is the complexity of that MDT decision. And this decision is made in probably about 90 seconds to 2 minutes. And that might be your life or your loved one's life. You're talking about a meeting that has 50, 60 cases on it lasting a few hours, and it's challenging, it's complex. So this is about the assessment of the patient in terms of staging. This is about how you manage the jaundice. And the key thing in our centre, certainly all these patients come to the centre to manage the jaundice. And certainly Helen has worked tirelessly on getting this through NHS England. And the key message here is these patients should be discussed with the MDT before the stent, before any intervention, because if it's done in the wrong way, it may deny patients any curative surgery, or they may die of cholangitis on that admission. And obviously then there's the options of treatment. But it is challenging, and surgery isn't suitable for everyone. And I gave this talk earlier on about all the options that are there and all the options that have been tried for cholangiocarcinoma, and there's basically 2.5 million options there in terms of what could be considered. Now, not everything there on that list is as effective as everything else. So in conclusion, and hopefully just about on time, cholangiocarcinoma is, I think, a less rare but aggressive cancer. I think radical resection can achieve long-term cure, and that does also include liver transplantation, because that is now available in the UK finally, and there is clearly the importance of the MDT approach. Thank you much.